Can you have a microphone, please? Dr. Pulak, how do you perceive about the current scenario in diabetes management in India, particularly if we concern about the clinical nutrition practices?
Thank you for inviting me in this CME about medical nutrition therapy. And as a physician point of view, when we practice in our chambers and clinics, what I feel that there are certain points that actually that it helps. It is a barrier for us to implement a proper medical nutrition therapy in patients. As we are practicing more in an urban setup, the problem may be little less in our part of the city or of the country, but in rural area it is more pronounced actually. Number one, the different lack of time and time of counseling the patients about the importance of medical nutrition therapy. That is very difficult. Lack of good dietitian backup in our clinics is also another shortcoming. So that we can talk to the patients, feel their needs and change their eating pattern, eating plans. That requires a lot of patience and good counseling that we really lack. And next, I feel that setting some goals, setting some small goals and encouraging the patients to achieve those goals, that requires a lot of follow-up and lot of patience on the part of the team that is taking care of this diabetes management, because just suggesting few drugs will not suffice in this regard, and it requires a teamwork. And most of the physicians which in our country, those who are practicing, are almost doing it single-handedly. So it becomes a huge task on their part to take care of the diabetes part and the medical part and their complications part. It is very difficult. And another thing is, even if we suggest something, on the part of the patient, whether their adherence is very poor. Only, as Dr. Siddhanta was showing, that only 1/3 or roughly 40% of the patients are adhering to the diet plans or whatever suggestions we are giving to them. So they are multifaceted. Maybe there are all more points in this, but these are the main thing I have felt in my clinical practice for the last 15 years.
We understand. Basically, we are focusing about the counseling, because the counseling is a very major part, apart from a physician's role. For the diabetes educators or clinical dietitians will take the part on these about the counseling. So what do you think about the diet charts, the printed diet chart, the same for the 1200 calorie, 1400 calorie, 600 calorie for the patients, or it should be a tailor-made diet prescription for the individual patient should be needed? So what's your take on this?
Definitely, I agree with your point that just supplying a diet chart is not going to solve your problem, because each every individual has its own preferences and choices, and sometimes there are cultural barriers also. If I want to help a patient from a Punjabi origin, I don't know about his food habits and his taste, and it is very difficult for me to convince him about the medical nutrition therapy. And this cultural barrier and you have to do you have to practice modern medicine along with your traditional food habits, along with your modern dietetics, and everything should come together. And in that case, tailor-made diet plan by registered dietitian is the foremost importance, I think. That's the need of the hour.
Thank you. I'm going to Dr. Udas. Any disparities happen in the socioeconomic group for the patients? What do you feel in the field of your practice?
That is a very important part because a socio-economic factor and cultural factor is more important. Not only that, also educational part is also important. for the management of diabetes, particularly the dietary habits. And for the dietary habits, Dr. Siddhanta has already mentioned, is not the glycemic control. It is a three-part is there. One is the glycemic control, second is the blood pressure, and third is the lipid control. So all three in combined produces or rather a macro and microvascular complication of diabetes. So basically what we rather suggest that all three things are important because to prevent the complications of diabetes, and that's why not only the glycemic control but also the dietary habits about the how to control the blood pressure. The total, he has mentioned about the total salt intake, and that is most important. So blood pressure control is also very important, and not only that, lipid control is also important. So he has mentioned about the different guidelines for ICMR2, RSSDI, what is the fat content of the diet. So all three things are important, and also the glycemic index of the food is most important. So which fruit is have a good glycemic, high glycemic index, that should be avoided. So that is the educational part. So that educational part, it depends upon the socio-economic status of the patient. So if the patient is educated, so he can, he knows what is the glycemic index and what is the complication of the, if I take the much salt and if I take the much trans fat and others. So all three things is very important, particularly in the important sociological or socio-economic factor. And not only that, some social customs is also very much important, because we are the Bengalis, আমরা বাঙালি কেউ এলে কী করি, আসো একটা মিষ্টি দিই। খাবারটা হচ্ছে আমাদের মিষ্টিটাই দেয়া, যে সে ডায়াবেটিক, তুমি ডায়াবেটিক একটা খাও কিছু হবে না, ডায়াবেটিস তো। কিন্তু আমার সোশ্যাল কাস্টম হচ্ছে কি, কেউ এলেই আমরা একটা মিষ্টি দিয়ে দেয়া, অন্য কিছু না। মানে এই যে হ্যাবিটসগুলো, দ্যাট অলসো ভেরি মাচ detrimental for the control of diabetes. So not only the other also education factor is also important, some cultural factor is also important. So all three things are most important to rather control the diabetes, particularly in respect to dietary habits.
Thank you. So my next question to Dr. Mukherjee. Dr. Mukherjee, in your daily practices in the field of endocrinology and also the diabetes, if any particular time, at any given point of time, a patient will ask you about the diet part. The diet part, what I will eat. Should I eat mango? Should I eat banana or everything? Or give me a diet prescriptions for that also. What's your take on this? And how do you tackle to this patient about the medical nutrition therapy? And what challenges you are facing in the terms of, because maybe you are prescribing some drugs like maybe biguanides, maybe sulfonylurea, and there are some challenges also, some obesity and also underweight. So how do you tackle in these cases in terms of medical nutrition therapy, and your complications are also challenges?
So I must accept that we hardly put much time on counseling patients about their diet. We almost hurry every time to complete our prescription, writing medicines. This is very important. If the patients ask whether to go for sweeteners, stevosides, as I practice mainly in the cities, so many of my patients are pre-educated with their own lifestyle, with their own medications and everything. So definitely we have to refer the patients to a dietitian, qualified dietitian, because we don't afford to spend so much of time to counsel about the diets. But thorough discussion needs to be done in the chambers as well, I admit and I accept, to counsel the patients about their diet, especially salt and especially fat intake. Say just asking the patient to have only salt less than 5 grams will make no sense until and unless we make them understand how to measure 5 grams. So that has to be implemented, that has to be conveyed to the patients, and definitely that has to be ensured that they are following those things at home.
True. So you mean this is counseling is very important to the
Very
clinical
much.
dietitian or diabetes educator in the clinical setup itself. Otherwise, only writing in theoretical aspect will no value in front of the patient because they're very layman, they will not understand about what they are saying.
Even if they understand, they will like to hear it from a dietitian if they are advised to do so.
True. True. My next question is Professor Subir. How do you feel about there are some gaps of limitations in existing nutrition management in India. So in traditional diet or conventional diet, conventional dietary practices also. So is there any kind of successful example from your end that it could be a positive approaches in front of the patients, or there is some gap you are finding from the patient?
Actually, there is a different cultural habits, different dietary pattern actually patients are following. So they don't have the correct knowledge actually. So sometimes actually we hardly get any time to counsel patients that already told that. But within this short span of time, at least I tell them at least to they can implement that they increase the intake of vegetables, fruits. So I told them that your plate, half of the plate should be filled with vegetables and fruits, and you can, and other half that should be carbohydrate and protein, and reduce the oil consumption. And many times that simple, just one 30-second talk, that is sometimes helpful also for them. And many of them don't know actually, they are not educated enough that they have to reduce the carbohydrate intake. So many of them are carbohydrate there, and sometimes it is also seen that in our patients, those even those who are receiving insulin, so we are unable to control the postprandial spikes. So definitely dietary intervention in that case is very much helpful. And also this dietary intervention is helpful is also to prevent hypoglycemia also. So when there is a meal gap, I always ask to take some nutritional intervention or like this. So that will prevent also hypoglycemia.
So my next question to Dr. Siddhanta, that you spoke a little bit about the meal replacement therapy and all the partial meal replacement therapy. So what's about your take on these clinical nutraceuticals or clinical nutritional supplement for the patients who are not having in traditional food or the conventional food in thoroughly, and about the adherence and the compliance of the diet, because maybe we're prescribing some calorie of the diet to a particular patient, X amount of protein, X amount of carbohydrate, X amount of the fat, vitamins, minerals, and also you talked about dietary fiber prolonged. So we know the role of the resistant starches, resistant fiber have a major role for controlling diabetes in spikes. So in particular any kind of food, maybe food is not properly cooked, maybe it's very high cooked with lot of oils, because if I ask the patient to have some kumru or pumpkin, maybe they have too much of fried kumru or fried potato, so it could be again increasing of the ROAs or free radicals, so that could be detrimental for the targeted organ in the cardiomyopathy or any syndromics or the non-communicable disease. So what is the nutrition supplements or nutraceuticals plays in a major role in this bridging the gap of a patient suffering from diabetes? Any challenges or adherence or compliances? Your take, please.
As enlightened by all the esteemed panelists, the role of diet is of paramount importance, but the sad part is we hardly give importance to it. Not only that, there has been a patient inertia regarding diet also. Diet and exercise ta bolta hai na. So there lies the importance of counseling the patient about the importance of diet and exercise. That is more important. To taper, not just to decrease your blood sugar level, to decrease your pill count. Diet and exercise is of paramount importance, and definitely it has to be individualized and tailor-made. Now coming to your actual question, definitely if the traditional meal plan will not suffice and if the patient is willing and affordability is not an issue, then probably, as I have reiterated in multiple original studies of our country, nutraceuticals and nutrition supplements definitely plays a very important role, not only in reducing your glycemic status, but also in improving your lipid profile, your other hormones, and definitely beneficial to a swarm of patients.
Thank you. So the end of the sessions, we are giving the end of the session. So we got